Good morning, everyone. External rotation contracture in brachial plexus birth palsy. We know that muscle imbalance in Erb's palsy leads to typical clinical signs like reduced passive external rotation and internal rotation contracture. When our children are asked to do hand-to-mouth movement, they have typical lateral trumpeting, and they have proportionate limitation of shoulder abduction and external rotation. But in a subset of patients, we found that they have good degrees of active external rotation. But when we ask to elevate the arm, they have flexed forearms and abducted arms. These abducted arms and flexed forearm are typically part of intermediate C7 palsy, or what is known as predominant C7 palsy in literature. These patients also had lack of active internal rotation, making them difficult to reach the belly. And they also had lack of passive internal rotation. This was making difficult the forearm to reach to the couch when attempted passively, and that is termed as external rotation contracture. So the aim of this study was to define the clinical synopsis of predominant C7 palsy, to describe possible biomechanical background, and to differentiate it from typical Erb's palsy. For this 765 patients which have enrolled in our comprehensive clinic, we included those presented for the first time to us after the first year of life. And out of those 266 patients, we excluded the ones who have underwent surgery or those with panplexopathy. Rest of 76 patients, we had 36 patients with intermediate palsy cohort, and those were the group we were interested to study in, and they were termed as group A, while 140 patients with Erb's palsy made the group B, and they act as a control group. In outcome measures, we use 6-point modified Mallet score. We measure active and passive shoulder range of motion, tricep strength, and wrist dorsiflexion strength to MMC. We also see what happens when an elbow extension splint or pedi-rep is applied to these elbows. And the pedi-rep test was turned positive when this improvement was more than 30 degrees of abduction. The type of trumpeting was also noticed. If a child required forward flexion to reach the mouth, that was termed as forward trumpeting. In results, we observed that modified Mallet score was statistically different in both typical and intermediate palsy, while global abduction was significantly less in intermediate palsy and global external rotation was significantly more. All the patients in intermediate palsy could not reach the midline, or their hand to belly function was 2.9, but it was normal in typical Erb's palsy. 90% of patients develop external rotation contracture in group A, while internal rotation contracture was seen in 88% of patients of group B. None of the patients in Erb's palsy had external rotation contracture. The results of pedi-rep was striking. We found that 95% of patients in group A had positive pedi-rep test, and abduction difference was 49 degrees compared to only 15 degrees in group B, suggesting no patients had positive pedi-rep test in Erb's palsy. This difference was statistically significant. Average forward trumpeting in group A patient was 37 degrees, while average lateral trumpeting was 50 degrees in group B. We also found that 70% of group A patients had triceps weakness, 25% patients had wrist dorsiflexion weakness, while these factors were normal in Erb's palsy group. 39 patients of intermediate palsy had elbow flexion deformity, while it was only 10% in group B, and these all three changes were statistically significant. In discussion, C7 supplies lower subscapularis and part of triceps and wrist dorsiflexor. In the presence of imbalance between C7 and C5-6, it leads to more external rotation at shoulder than internal rotation. And if it remains untreated, eventually it would end up into external rotation contracture. When the subscapularis, which is supplied by C7, it provides an important anterior stabilizer force while doing shoulder elevation. If this subscapularis is non-functional or weak, while attempting shoulder elevation, this humeral head subluxates in front, and this is known as anterior superior pseudo escape. We proved this theory with a CT scan study wherein a child's humeral head were located in rest, but in abduction, this humeral head got subluxated anteriorly. When we placed the pedi-rep with the help of biceps flexion, biceps pull down, these humeral heads were reduced in position, and it leads to improved abduction. What is the treatment application of this study? So if we offer conventional internal rotator release and conjoint tendon transfer to this cohort of patient, we can worsen the existing internal rotator weakness, induce external rotation contracture and anterior instability, which in turn will hamper the ability of a child to abduct the arm. So we have to come up with new methods of treatment. What we have started doing is arthroscopic posterior capsule release to release this external rotation contracture. In a subset of patients, we have also offered latissimus dorsi to subscapularis transfer to improve internal rotator strength. Pectoralis major transposition to improve anterior stability has yielded good abduction in certain patients. Thus, clinicians should be well aware of C5-6 and C7 cohort to differentiate between them at the outset. In limitation of shoulder, external rotation is a key sign of typical Erb's palsy, while limitation of abduction is a key sign of predominant C7 palsy. Pedirep test is positive in intermediate palsy, while it is negative in Erb's palsy. Internal rotation contracture is a sign of typical Erb's palsy, while external rotation contracture is a sign of predominant C7 palsy. Hand to belly was difficult in C7 group, and their triceps strength was suboptimal. And trumpeting was lateral, typical in typical palsy, while it was forward trumpeting in C7 palsy. In conclusion, clinical synopsis of intermediate type of brachial palsy is entirely different than that of typical C5-6 Erb's palsy, and external rotation contracture should be recognized well in time in the clinical examination to offer them optimum treatment. Thank you very much for your kind attention.